Yes, yes, we can see it.
Okay, brilliant, brilliant. Okay, so I wouldn't say I'm an expert. I do okay with the endoscopy, and I'm involved with the WFNS endoscopy and IFNE as well. So a lot of work that goes in there. This is actually a talk which is meant for trainees and actually not meant for all the seniors who are sitting there. Endoscopic third ventriculostomy, we use this to treat non-communicating hydrocephalus generally. Hole is made in the floor of the third ventricle to bypass the obstruction to the CSF flow. And I'm not going to show a video showing how a third ventriculostomy is done, but I'm just going to move on with it. History dates back to 1910 when a cystoscope was used to fulgurate the choroid plexus. Dendy refined this procedure using calling it a ventriculoscopy. In 1922, he described the use of an endoscope to perform plexectomy. Mixter in 23 did a first ETV in a child with congenital hydrocephalus using a ureteroscope and a probe. Popularity actually waned because there was high mortality and larger instruments. We couldn't see much. We didn't know what was going on. In 80s, when all this improved and the cameras and the resolution improved and our fibers were very good quality, then there was the rediscovery of neuroendoscopy. Operative technique is simple and it doesn't take long, although there were risks associated with it. Indications generally were aqueductal stenosis, tumors with hydrocephalus, although there was risk reported with germanomas. When you pass the scope, you can have the tract filled with germinal cells. There is idiopathic stenosis of Magendie and Luschka, for which this was used as well, and posterior fossa tumors, as we said. Patients with repeated shunt infections, they would change into ETV. And then isolated lateral ventricle, Dandy Walker. So you are doing a septostomy at the same time or a stent through the third. Slit ventricle syndrome, there have been case reports. And recently, communicating hydrocephalus has also become a part of ETV armamentarium. And many patients have been reported with about 70% success rate. Favorable features for ETV, we know about this. So there's a ETV success score by Kulkarni et al. But generally, if age more than 6 months at the time of diagnosis, at the time of procedure, no prior radiation, no history of meningitis or hemorrhage. Radiological features, we all know about them. Anything that causes pressure and pushes the third ventricle or the lateral ventricle up and down, obviously gives you a good idea that these patients will benefit from this. Basic operation, you just determine the entry point and enter the ventricular system. You find the foramen Monro, as very nicely shown earlier as well, and inspect the floor of the third ventricle, perforate the floor, and enlarge the perforation, and then inspect the prepontine cistern to ensure there is no more pressure or there is no more blockage of any kind there or no adhesions there. Let's come to some of this anatomy. We all know about the ventricular system. A lot of this has been discussed earlier as well. The important thing to remember is that you need to look at what size the foramen Monro is, as Ramesh just pointed out. The other important thing to remember is that we know that there is no choroid plexus in the anterior and the posterior horns of the ventricle, and rest of them have the choroid plexus. Initially, our objective, generally, textbook would say that you make a hole 1 centimeter in front of the coronal suture and about 3.5 centimeter lateral, and then you come in through and you can go in for this purpose going through the foramen Monro. Entry point is always difficult. Many techniques have been described. Many people have described 1 to 2 centimeter around the coronal suture, majority of them describing it in front of the coronal suture. What are the problems that you could have when you make a burr hole? Obviously, burr hole, generally now what we do is we use, as Ramesh pointed out, we use lots of imaging. We need to know exactly on coronal, sagittal, and axial where the foramen Monro is, and join that line to where our entry point is going to be, and then join that all the way to the root, to the skull, and you use that line. And this can be done if you don't have image guidance, just by the scans and measurements and how far in front or back of the coronal suture burr hole, if it's too small, you're going if you have a large burr hole, then the angulation might be easier. So if you're coming in medially, you make sure that medially you do take a lot of bone to ensure that there is no problem getting in there. Anatomy of the lateral ventricle has been discussed so many times here, but I think it's always worth revising. And I'm going to show a video which shows all these anatomy and what are the structures which are shown here. This is the most important picture generally that we have seen, and we have talked about fornix and the septal vein. So if you come onto the right side of the ventricle and you're entering from the right side, if your foramen is large enough, the important thing to understand is that if you have the septal vein on your side laterally, then you know that you are on the right side, you're not on the left side. Because if you try to do a ETV through the opposite ventricle, if you go in by mistake, then you're going to cause damage to the fornix and also the vessels trying to come in. So I think all this is important for us to understand. So let's look at some of the anatomical structures that are in the lateral ventricle that are potential for us to damage if we are not using image guidance or if you're not careful. So start with thalamus. It is located right in the center of the lateral ventricle. It is the lateral ventricle is around superior, inferior, and posterior parts of the thalamus. Body is located above, hence superior part forms the floor of the body. The atrium, obviously, and the occipital horn are posterior to it, and hence posterior surface of the pulmonar forms the anterior wall of the atrium. The temporal horn is inferolateral, so it comes all the way around, hence forms the medial edge of the roof of the temporal. So I think it's important to understand that this lies right in the middle and is surrounded by some structures. And you can see that fornix with its columns and the body, and it just goes all the way around and forms the fimbria, and the crus column comes all the way around. So you need to understand that thalamus is encircled by 2-3 structures, and all those you need to know. Again, if you look at the fornix, which also wraps around the thalamus, just like the caudate nucleus as well. So it consists of hippocampal mammillary tract fibers, and they originate from the hippocampus and dentate gyrus and goes all the way to the temporal lobe. So it revolves around like that, and you can see the column of the fornix, the body, and then going up to the fimbria after the crus. What about the caudate nucleus? And you can see this very nicely in the sagittal image. That caudate with its head and the body and then the tail, and then ends up in the amygdala. And the head bulges into the lateral wall of the frontal horn and the body of the lateral ventricle. The body forms the part of the lateral wall of the atrium, just like the other structures as well. And the tail extends from atrium into the roof of the temporal horn and is continuous with the amygdala nucleus in the tip of the temporal horn itself. Again, if you see it on axial and coronal images as well, so you can see that the caudate nucleus is like seahorse shape with the head and the body and the tail and ending up in amygdala. Whereas if you see the column itself and then the body and then comes around of the hippocampus itself and ending up there. So all these structures are very nicely shown in these diagrams by Roton. Let's just quickly look at the anatomy when you put in the scope. So actually this video does not belong to me. I borrowed it from a friend who didn't know where it came from, but it was so nice that I use it in all the education. So you can see the anterior septal vein, which is lying in front, even the right side of the ventricle. You see the choroid plexus there, and the thalamostriate vein dividing the thalamus and distriatum itself. And the septum comes in the middle. So just going to go there. And so keep going. And the fornix body is lying medial to that. And then we go posteriorly. And the choroid plexus goes all the way down. And as we talked about, sorry. So that's the thalamostriate vein dividing the thalamus, which is here, and the caudate nucleus above. That's very nicely shown. and the caudate vein, which comes in and joins the thalamus striate itself. And we can see the fornix itself coming around and the body lying here. And then once you go in into the third ventricle through the foramen Monroe, and you see the parts that we can see there. So fornix itself, founding the borders of the foramen Monroe, the anterior commissure just coming below that. The chasm that follows that. And as you go down, you can see the supraoptic recess just above the optics. The chasm itself, the dorsum celli, and you can see part of the basilar there and the two mammillary bodies that we can see. So, when you're doing an ETV, as we talked about, needs to be done. It can be done in various ways, and we'll talk about it and what complications we need to avoid while we're doing this. So once we do the ETV, we look inside, we make sure there is no problem inside, there's no adhesions. You can see the dura of the, there we go. So basilar artery is shown here. The clavis dura is shown here, and there is no adhesions underneath. So just going to move up. So if we look at from the top, and we are seeing both the foramen Monroe, and we can see the genu of the corpus callosum right in front. And then we see the caudate nucleus on both sides, so the body and the tail, which goes all the way to the back. And then thalamus. Thalamus striate veins are important to preserve. Having said that, for some tumors, if they're essential, you can take it. And now many people are using this approach for some tumors underneath. Choroid plexus, foramen Monroe on both sides. The important thing to understand is the internal capsule genu lies here, and if you damage something lateral to that, you can cause serious problems lateral to the foramen Monroe, and you don't want to be doing that. So same thing is shown here, that internal capsule, the genu itself lying very close to the foramen Monroe, lateral right in the middle. And so I think it's important that you do not damage that, or if you have the burr 2 medial and you have to come laterally, you could do that. So don't do that, and try not to damage any veins. Further trajectory maneuvers, if you need to look at the scan beforehand, just like Ramesh showed, that large size or small size for a Monroe, so it's important which side you're going to enter from, so you choose your entry point. Third ventricle mammillary bodies are important to preserve, as they can cause enterogate amnesia. And if you go into laterally making a hole, or if the Fogarty slips onto one side, you've got the third on both sides, and you can cause third nerve palsy, leading to all the features that could give rise to serious diplopia later on. Third ventricle itself is a narrow funnel-shaped midline cavity, communicates anterior superiorly with lateral ventricle. We know all about this. Posterior to the fourth has all these structures, and I'm just going to go quickly. Fornix, so you can see there's column, the body, and the fimbria that they go all around it, and the crus is shown there as well. Body is there as well, and obviously there are the important thing to understand is that from the function, the left side of the fornix, which is the left ventricle fornix, it deals with the verbal memory, whereas the right one deals with visual spatial memory. The fornix carries fibers from both caudal and rostral nerve hippocampus, as we had shown earlier. So the lateral fibers of the fornix have interoceptive signals and involved with learning, emotion, and motivational memory. So if you damage the lateral fibers, then those will be affected. Medial fibers it recognizes for special contact, but overall, you can have an enterograde amnesia if you damage the fornix while doing this. So let's look at the medial parts of the third one, looking from the medial side. So you can see body itself, body of the fornix, column of the fornix, foramen Monroe entry. We're looking at the optic chasm, and we have seen all this from the top. Infundibular recess, supraoptic recess. We saw all this when we saw the video. A basilar artery, as Ramesh just showed, nicely shown that 30% of them lie behind the memory, but the ones in front, you have to be careful, especially the one which has a basilar aneurysm associated with it. So you can have this. So irrigate, irrigate. This video actually belongs to Shlomi, who shared this with us. And they found an aneurysm there, and that was taken care of. And this patient survived. Anterior commissure, lamina terminalis. So in some cases where if you have no space to make an opening, you can make an opening here. The important thing to understand is that you have lamina terminalis cistern in a cistern in front with vessels, so you need to protect that as well. So endoscopic view, we just saw this. So fornix itself just above, and there are freehand methods as well, as we talked about. So, but you need to evaluate beforehand and make sure that you see the coronal, sagittal, and axial images, and then you design a plan and then use a scope. If you use the stereotactic method, again, the same point that you use the foramen Monro as center, and you extend that center all the way to your opening, and then you bring it back all to the skin, and that's where your entry point is going to be. So you enter the scope, you cut the dura in crochet fashion. You use 14 French trocar. Once the scope goes in, usual, you have different ways of penetrating the floor. You can have a blunt probe. Some people use electrocoagulation. I only use it when it's thick, scarred opening that I need to make. The laser probe can be used as well, and some people use ultrasonic contact probe as well. And then you end up with Fogarty catheter. Continuous irrigation with ringers is important, and temperature maintenance is very important because you can have serious problems, and your the fluid coming out needs to be appropriate as well. And then imaging is usually performed 6 to 8 weeks, usually post-operatively, because you don't expect the ventricles to come down straight away. So many must explore the prepontine space and open membrane of Lilicust for a successful ETV. Lilicust membrane extends from the upper border of dorsum tilicelli all the way to the anterior edge of the mammary body. So with image guidance, what we have shown recently as well, that generally if you try to make a conventional burr hole, general thing is a centimeter or 0.5 centimeter behind. And some of these patients can be too far back, but you need to be sure that you're not causing problems to the premotor area. Again, entry point, if you're going to be coming too anteriorly, you can cause problems. And if you come too posteriorly, you can cause problems as well. And that's important, that you don't want to be damaging motor cortex and frenulum and fornix. So just showing, it's just we had electricity failure, so it just switched on to the generator. So without image guidance, you may end up with the wrong trajectory and enter into the opposite side of foramen. As we said, that might cause bilateral fornix damage, and you don't want to be doing that. A two lateral approach may cause damage to the fornix and cortical injury, so you don't want to be doing that, because if you're coming too lateral, you'll be hitting the lateral wall of the fornix. So complications generally, intraoperatively, you can have bradycardia in about 40% of the cases. You can have choroid plexus injury. Basilar artery injury is up to 0.05%, and some cases reported much higher. I've only seen in 4 videos that I've seen myself. Otherwise, it's very, very rare. Post-operative, you can have all these problems that are shown here. Delayed, you can have seizures, and there have been reports of a failure and sudden death. But obviously, complications, you need to be aware that you could have an aneurysm, and just be sure that the basilar doesn't come and is stuck up onto where you're going to be making the hole. So the basilar being anterior to mammillary body, it's all been shown. All the complications are shown here. So hypothalamic injury, fornix injury, oculomotor injury, all these can happen, but you need to be wary and you know how to avoid them. There's a grading system for fornix contusion. So if lateral fibers and medial fibers, which one are involved? So in a large study collected over time, he came up with this score, and we're using this at the moment. Although having said that, once you are very wary, then your incidence goes down and down. That incidence of fornix contusion is really low once you're especially doing a study and you're also grading it at the same time. So this is again a small video. So just how we are planning. So if you see, you use the foramen Monroe joint where you're going to make the hole and just extend it up. So that's your lateral limit, and do the same thing on your sagittal, and that's how you build it up. So let's just going to go, and once you have planned this, you marked it. So this is behind the coronal suture that we're going. So usually use a flap so that, and then you also use a pericranial flap so that you have a double breast protection of not having a CSF leak. Well, this is a small for Monroe, although we did everything, but my resident made the burr hole slightly interior, and that's why I will show you that we did make a contusion onto the fornix when you're coming out. So this is at the end, and you can see the contusion all the way along because our entry point was not in the right place despite using the image guidance. So that means that even if you use the image guidance, but you still make the burr hole in the wrong place, you will run into trouble. So
Salman, you have 2 minutes.
I'm actually done. So I'm grateful. Thank you for listening. And it's you're all most welcome to Pakistan at some stage. Thank you.
Thank you very much, Salman. That was an excellent talk, as usual. So there was one question, somebody had asked whether in case of a thick membrane below the floor, do you open it too?
Yes, I think if you're using image guidance, it's easy because you know where exactly your basilar is. You've already calculated it, you've already seen it, and you go in front of it. If you can't, then sometimes what I do is in that particular case, the basilar was right up, and we made a opening very close to the dorsum celli, and if you do that, then it's much easier. And if you're really stuck for whatever reason, then you can also open the lamina terminalis. Having said that, it's usually not required, and there are vessels anterior to that as well, so you should be careful.
Thank you, Salman.